Welcome, everyone. Happy to have you all here. My name is Todd Terrazas, and I'm the Executive Director of the AILA community. We're a nonprofit here in Los Angeles focusing on accelerating innovation for social good. And so we host a number of different types of events throughout the year, now all of them being virtual. And we're really excited about today's event, focusing on digital health during a pandemic. And so we're focusing on, have three amazing companies from California that have been, shifting their operations to really help address the COVID-19 crisis that we're all in right now. And so we have Indu from Catalyst at Health 2.0 who will be moderating this discussion. And so afterwards, if you mind, just please keep your mic and your video off during the show. And then if you have questions, you can put it in the chat, or we have this thing called Slido where you can actually ask, put in your questions and upvote other people's questions. And so there'll be a time at the very end for you to address our panelists and have a conversation. And but before that, just please sit back, enjoy, and take some notes if you need to. And we'll be recording this and uploading to YouTube afterwards. Without further ado, here's Indu to introduce the panelists.
Thanks so much, Todd. It's really wonderful to be here. So welcome to this panel. We're living at a time of such disruption that it's really wonderful. I appreciate people making the time to be here and to the panelists for joining us. So I'm the co-founder and president of Catalyst at Health 2.0, which is a spin-off of the Health 2.0 conferences company. And we work primarily on digital health partnering and innovation programs. So today I'm going to be joined by three incredible companies that we're really excited to hear from. One hails from Los Angeles, two from Northern California. One of our panelists is running a little late, so they may join halfway through, but I will introduce Joe Bhakti from Quantgene when he can make it. But who we do have so far is, let me begin with Kash Kapadia. He is the CEO and founder of Anchor Health. Anchor Health actually launched at Health 2.0 last fall. They're a full stack AI company based in Palo Alto that helps individuals navigate healthcare by connecting them with the best products and services in partnership with employers and healthcare enterprises. Kash previously served a number of roles, but most recently was VP and General Manager of Digital Health at Stanford Healthcare. Next, we have Adam Silverman, Dr. Adam Silverman, who's currently the Chief Medical Officer at Syllable. They're a conversational AI healthcare company based in Sunnyvale, California. Dr. Silverman is also an internist who has founded his own company, Upstream Solutions, in an effort to work with like-minded individuals tackling healthcare's most vexing problems. So I'd love to welcome both these companies, and I'd like to begin by asking perhaps, Kash, for you to go first, to please set the stage and describe kind of what your company was attempting to address in the healthcare ecosystem prior to COVID, and then what observations led you to kind of pivot the company into the direction that you're going in now.
Sure, thanks so much, Indu. So Anchor Health champions individuals in navigating healthcare, as Indu described. And we do so in partnership with healthcare enterprises, payers, providers, employers, et cetera. And we aim to bring best of breed services and products to champion the individual. So our use cases range, from the common that are very difficult to execute, things like booking appointments, understanding a bill, getting discounts, new medications. All these things are things you take for granted in other places, but as we all know in healthcare, it's tremendously difficult to execute. What we found with COVID was that we found ourselves almost in the eye of the storm, because if healthcare was difficult to navigate pre-COVID, COVID only exacerbated the crisis of US healthcare, and it amplified the need for a platform that helps individuals get things done. And through that process, we found, we didn't pivot the company as much as we said, in the short term, this is priority number one in healthcare. So we absolutely need to focus on it. So we made a number of updates in our app, and we improved a lot of our back-end integrations in order to serve the population with COVID tools. So that, if anything, I think it's just amplified the need for a platform that brings the world of healthcare together to champion the individual.
And I'll just tell the folks listening to this that we're going to come back in a couple minutes after we get these introductions and see some see these technologies in action. So we're going to come back to you, Cash. Thank you. Adam, do you want to sort of set the stage again? Another AI company dealing kind of in this conversational AI category.
Sure. And thanks, Indu. Thanks to the AI LA team, and Cash and Joe, thanks for being so kind and sharing the stage with me too. You know, Indu, you described us the way I would describe us. We're a conversational AI company, but in a way that's kind of like saying Tesla is just a car company, because AI, like the automobile, is a tool. And if you wield it the right way, you can really transform things and transform people. But Syllable is also a healthcare services company, and similar to Cash, we use the tool of artificial intelligence to make humans and the human experience of healthcare better, in a way, the same way that Tesla uses the EV to evolve the way we think about the automobile. So we like to say at Syllable that we seek to be the shortest line between a patient and the care that they deserve. Because if you think about it, it really sucks to be a patient today. Healthcare is broken and expensive. Cash is absolutely right. And the patient journey requires a lot of grit and determination and stamina. But these are characteristics that lag when you're not feeling well. So the problem in healthcare is that they have historically thrown humans at the patient journey problem. And there's this stubborn belief. But it's true that if the person, that the human-to-human contact is important if you're going to build a loyal patient following, if the human that the patient is talking to has the knowledge, skills, and attitudes that really are necessary to engender human connection. But I think as many of us and many of our family members have found, that the patient-health system interaction frequently falls short of where we would like it to be. So what good's a human that doesn't exude human qualities? And this is sort of where Syllable comes in. Our conversational AI speaks patient, so we understand how real people, not doctors or healthcare systems, talk about their health. Our artificial intelligence is always there, it's always on. It always provides consistent information, the same message, no matter how many different people ask the same question. And it's available without any wait time. And we also understand data. So we know how to quickly and easily organize the information that's hidden within all of these endpoint solutions and EHR systems that proliferate in our hospitals. And so we use the data science and the artificial intelligence to assist patients by automating their journey, wherever they may be, on the phone or on the web, using whatever channel they're most comfortable with. And that could be voice or that could be text. And to date, we've helped over 40 million patients on the web and 2 million phone users. So then you have COVID. So COVID took already stressed health systems and almost broke them. Requests for information went unmet. There just was not the requisite information on websites, and telecommunication systems were overwhelmed by callers. And the patient experience was one of gridlock. So we tailored our hospital AI to specifically deliver COVID information and transactions. Our web bot and our phone bots both disseminate information, screen for symptoms, and navigate patients to the appropriate information, testing, or care delivery based on their own individual risks or needs, as well as the health system resources. So we were able to do this all without involving a human being and adding additional stress onto these already stressed health systems. And this was a critical point of success for both us as a company and our partners. So in the end, COVID-19 was an unfortunate game changer for us.
Yeah, I hear that, Adam, and at the same time that, digital technology, we've all been trying to sort of increase the adoption of it. And if it is tragic that it took this to grease the wheels, but we all hope for, eventually sort of a better outcome for all. So I'm going to come back to Cash. And so far we've heard from both Cash and Adam around different approaches to kind of the AI engine helping consumers navigate, in Cash's case, kind of across a set of very disparate services, really building that kind of individual profile. And in Adam's case, around helping kind of largely healthcare providers in the enterprise side make all of their services and information much more accessible and easy to navigate for the patient/consumer. Cash, I think you're going to kind of put this into context for us and present a little bit more about how your AI works. And I think you've prepared a few slides and a demo.
Oh, sure. Absolutely. Let me get that going here. I'm just going to share the screen here. So just to give you, just to put what I said in a more structured format, the focus, what are the top 5 things you need to know about Anchor Health? And I'll show a video really shortly, it'll come to life. You know, we champion individuals in navigating healthcare. Right? We create tangible value in partnership with enterprises. And it's critical to understand that healthcare is a complex beast of an industry, and it is enormous. So if you aim to champion the individual, you can't do so as an island. You must partner with all the enterprises that serve the individual. So especially when you're talking about booking appointments, are they with the enterprises that the individual wants to book the appointment with, for example? When you're talking about drug discounts, are there enterprises that are already working on this problem that you can leverage? So in this way, we're able to help the individual get information, move to the decision that's right for them, and then actually execute an efficient interaction, engagement, transaction, depending on what their need is. So we're able to take them on that continuous journey. I say we're building a full stack end-to-end AI platform. The reason we use those terms is that we're using many algorithms in the back end to figure out what's the right resource to present to you. But critically, our engagement mechanism is also conversational. So we're using conversational AI on the front end, which powers our front ends in our own apps, as well as on third-party platforms like Facebook Messenger, for example, where we are now live. And we also then connect that to a back end. And that entire end-to-end experience is something that allows us to really cater that experience to the individual, to pay attention to things like empathy, to things like personalization, where we can, to reduce bias and be able to really control that end-to-end experience. We are integrating point solutions to connect the dots of healthcare. So the critical thing to think about Anchor is that this is an umbrella platform, much like you might experience with an Expedia or an Amazon, which is trying to say, well, it's not just Barnes & Noble that we're creating the front end for. We're trying to make this the platform that you use to engage with healthcare. And critically, we're going to meet you where you are. So we'll meet you in apps, and we meet you on third-party platforms with the same back-end platform, with the same consistent experience and a handoff between the two. And then finally, as Adam rightly pointed out, for too long has healthcare thrown many humans at a problem. That's expensive. That doesn't work for anybody. The entities that have to hire that much more and increase their cost base at a time of financial difficulty, frankly, and it doesn't help the individual either because it takes longer to get things done. So we aim, obviously, with our digital platform for the next 10 years to be able to automate as many of those journeys as possible. But in the event that something like a denied claim or a prior authorization or a surprise bill that comes out of nowhere, which increasingly is a challenge we're seeing with COVID, comes to the fore, we are able to augment our human best-in-class advocates with that platform and enable them to give you personalized one-on-one guidance as well. That's a premium offering on our platform. So there's a quick video that I could show you, and let me just make sure. Oh, it is. I don't think that's full screen. I don't see a full screen thing here. Let me do this. Let me get out of this. I'll share it straight from my desktop. All right. Hopefully you guys can see that.
Is there audio cache?
I'm sorry?
Is there supposed to be audio for this?
There is an audio. Let me try to see if I can mute the thing.
When you share your screen, you need to click a checkbox.
Oh, is it not sharing right now?
It is, but the audio, yeah.
Just, I guess if you just reshare your screen, so exit and then reshare your screen, you'll see there's a checkbox with add audio.
All right, sorry if that, sorry if the audio didn't come across there.
That's okay. I think we got to see the screenshots and the experience. So
fantastic. And then, you know, just one thing I'll leave you guys with, you know, what we've done specifically for COVID is we introduced both a specific module where we have things like COVID trackers, triage tools, the ability to understand where you can get tested. And then we also enhanced our platform on the back end where we embedded COVID related information into regular things. If you're searching for urgent care, for example, you now have what is arguably one of the most powerful urgent care searches in the US today, because it combines not just the convenience of, you know, is it open and how far is it and how much time will it take to get there and booking appointments and such, but it also goes deep into healthcare, whereby we have information on price transparency, on coverage, which insurance is accepted. Does it do COVID testing? Is it confirmed to do COVID testing or not? And all of that, it took us a while to build it because we did it with human verified data. So we have a very accurate data set as a result of that. Obviously things keep changing, so we got to keep up with it, but it is, we've made a significant enhancement to that. And then on the financial front, the advocacy stuff that you saw there, you know, previously we were handling things like, you got a denied claim or an explanation of benefits that you don't know whether that's an actual, you know, claim. Do you have to pay that? Is it a bill? What is that? With COVID, there was a statement that went out that said, well, COVID testing is free. What people are now seeing is that bills are coming through, and often, sometimes there are mistakes. Sometimes it has to do with a COVID-related visit, but then the other service is delivered. And people are very confused. I thought this was free, but now I'm getting charged for this clinic visit. I'm getting charged for these other fees if there was an admission. And we are able to sort through all that complexity. That obviously is something that comes with a premium membership. You can buy that. One of our tenets is that we want to democratize access to premium resources. You don't have to be an employee of a very forward-thinking company that's willing to pay for this for you. You can buy this yourself. If this were something you choose to buy for the members of this audience, we're giving a 25% off our premium membership. That's the code right there, AILA Health 20. And it's going to be valid for about 72 hours, given that this is going to be on YouTube for a very long time. So we got to keep that in check. But better still, we are actively happy to work with your employer to get this covered for you. And indeed, that is a win-win for everybody concerned. If you connect us with the head of HR or benefits or a business sponsor within your organization, we'd more than happy to get that, you know, make that free for you and then make that a benefit available to you and your colleagues. So with that, I'll stop there.
Thanks so much, Kash. So a question for you.
Yep.
As you're building this sort of AI engine around the individual and attempting to advocate for them, how are you training the AI on the personal sort of data about me? Like, where did those feeds come from? And then how does that, how do you then use that to personalize the navigation choices I might have? And while you're answering that, I also want you to sort of speak to where in the user experience I might be consenting to different sort of pieces of data about myself to enhance that experience.
Yeah, absolutely. So we have multiple touch points. So you could download the app. Let's just talk about the app, for example. If you were to download the app, you can register with us. And at that point, we know very little about you. So a lot of the responses beyond, let's just say, whatever you've picked as your username and ID and things like that. So a lot of our responses are going to be deliberately neutral in that we don't aim to try to get invasive in terms of getting data about you that you didn't know we had. And we don't do that. If you were to register and actually sign up as a premium member, or if you were to register and upload your insurance information and get more, and which are all explicit steps that you take as an individual, we are then able to factor that into the background when we serve results. There are also explicit ways you can give us information during the course of a conversation. The most simple and obvious one is you're looking for search, and you say, use my current location. Well, now you've given us your GPS coordinates, and that was a very deliberate, specific opt-in there. So that's, for example, in the app. When you access us in things like Facebook Messenger, for example, it's a subset of that capability. We're not going to be giving you, detailed health-related, that has to do with personal information. So as a result, it's pretty much neutral. We just give you the neutral experience over there. We are able to message you one-on-one should you hit upon a challenge, because we have that capability to interject with a human if we need to, but it is largely going to be a completely neutral experience, just based on whatever intent you express through the conversation. So we're very careful about not wanting to overstep our boundaries there. And that's just how we consider championship. Obviously, at any time, you can tell us that, no, look, I don't want to be part of this, or I want out, and delete what you've got, and that's all in keeping with regulations. If you're on our website, we don't really do that much at all. We don't even offer a web app at this time. We have the capability to do so. We haven't done that. So that's just in terms of that intent-driven thing. On the back end, for things like health records, we have the ability to aggregate health records across 10,000 facilities across the United States, give you that comprehensive health record, enable you to share that with who you want. Those are all very specific, explicit steps that you would take. And us factoring that into the responses we give you will also be very explicit. Largely at this point, at this time, I don't want to oversell the AI, right? Because this is something that is a work in progress that is going to be developing as we move forward. We are largely focused on, again, very simple things, trying to understand your intent correctly, right? Is your query related to a health condition, or is it related to a drug? And did we get that right? And how do we not respond with something inappropriate when you've asked about something completely normal, right? Depending on who's using it. So a lot of our challenges just have to do with that. We've significantly, we're significantly investing in that capability, if you may. We are, whether it be pre-training data, whether it be just how do you eliminate any kind of bias that may creep in? How do you express empathy to the extent we can? Do we want to get too chatty? Do we want to get too pally? What's the tone that we want to set with you, et cetera? So we're very focused on a lot of those aspects as well.
Thanks so much, Kash. So we're going to come back to you as we think a little bit about business models too, because I know those are interesting and shifting now. So Adam, you've prepared a presentation to take us through the Syllable experience.
Okay.
Why don't you cue that up next?
Okay. Let's see. Can you see my presentation, or do you see Yosemite?
We see it.
Okay, perfect. I feel like we're playing Zoom bingo. Okay. So that's me. I'm the least important part of the organization. So, and you talk about the problem that we're trying to solve. Healthcare's dirty little secret, when you think about all the press that digital health gets, is that healthcare is still incredibly analog. People like to interact with their doctors and their health systems on the telephone. So when you look at the traffic that comes into a health system, it is vastly different than just about any other industry that you see today. So over 87% of the traffic coming into a health system is on phone, and only less than 13% come in on the web. And that really has to inform the strategy that health systems use. Unfortunately, it hasn't necessarily done that. They spent a lot of money on the web, and they're still doing phone the same old way they've done it, with Cisco routers and a lot of people actually answering phone calls. The other interesting thing is that when you look at web conversions and the ability to do transactions over the web, very few transactions occur in healthcare over the web, and even fewer over the phone. In terms of search engine usage, I mean, the first thing I always notice when I go and try to search on a health system website is it's not what you expect it to be. And yet people treat it the way they treat Google. You know, if they're looking for an ATM near them, they're going to go to a Google search page and they're going to ask for ATM near me. And that's what they try to do on a health system website. Like, I have sarcoidosis, what's the best doctor for me? And yet the search capabilities are far more rudimentary and therefore not particularly helpful for them. Healthcare also suffers from this huge long tail phenomenon. So, you know, the vast majority of utilization is around a very small number of web pages. Yet health systems spend a ton of time, activity, and money on developing very large data sets within their web footprints, much of which goes unnoticed by the vast majority of people. So there are all of these things that are so much different than what we expect from other organizations and other industries that it really is ripe to do the types of thing that Cash and Syllable are trying to do, which is, you know, how do you automate some of the stuff? How do you help the consumer, you know, do some of the legwork so that they're not dealing with this monumental challenge of trying to get the care that they're looking for at a time when they're really not feeling good for it. So we've created basically a platform that has a voice and a web assistant, and then we generate significant insights from that information because our artificial intelligence sits lightly on a website. We use a JavaScript injector that injects a chatbot on a website. And once it's injected on the website, we can follow users on their entire journey. We can follow them from web to phone. We can follow them across their web experience. And then if we put our AI on the phone, we can similarly follow the entire patient journey on the telephone. And even if they convert to a digital medium, we can follow that as well. And so it presents to the health system a much more holistic view of what the patient's experiencing, which is usually much different than the C-suite thinks the patients are experiencing. So our voice assistant, we've developed a cloud-based telephony solution. We answer 100% of all inbound phone calls. And on day one, based on the knowledge graph that we can create from all publicly facing information that a health system might have, we're able to automate 40% of the phone calls on day one, and usually 70% within the first couple of months. We can automate scheduling, which is a huge use case for health systems now. COVID decimated, you know, ambulatory care. And they're really struggling now on how to get some of those procedures and office visits to come back either virtually via telemedicine or in person in areas where there's less penetration of COVID-19. But these really are the two prime use cases we're hearing from our customers. Help us with phone calls and then help us get patients in the door and do scheduling. Web, similarly, it's the same AI, it's just a different user interface. You know, once we build a knowledge graph for an organization, that knowledge graph powers all of our products, whether it's the phone assistant, the web assistant, an intelligent search bar, or any other product that we develop. That's really the power that's underneath the hood at Syllable, is the fact that we have to build the knowledge graph once, and then we're able to power all of the tools that we utilize for a particular health system. Now, what I want to show you is just a quick demo of sort of a phone to web conversion. So one of our value propositions to our health systems is to say, listen, you have to recognize that the majority of your traffic is audio. It's coming in analog on the telephone. So we can help you with that, and we can help you with that from day one. But ultimately what you want to do is you want to begin to migrate people from analog to digital. And so we take the opportunity whenever possible and whenever a patient is willing to move them in that journey to digital. So what we're going to show you on this demo, hopefully you can hear it. If not, I'll stop it. Is that we call into the health system. The bot picks up and asks what we can do for them. Patient says, I want to schedule an appointment. And then we send them an SMS text message with a link that takes them to the web and enables them to digitally schedule an appointment. So let's see if we can get this to work.
Welcome to Weill Cornell Medical Center. How may I help you?
I need to schedule an appointment.
I can help you schedule an appointment online. May I send a link to 5125652179?
Yes, thank you.
Great. I've sent a text message with instructions. Thank you.
Notice that I confirmed my phone number and then I immediately received a text message. I can follow this link and land on a specific page within the web assistant. Since I already indicated that my need was to schedule an appointment, the next question has to do with who the appointment will be with. I need to see a doctor. This doctor's name is Ramos. Elizabeth. And now we're looking in Epic to see what kind of appointments this specific provider has available. These will differ according to the provider as well as the customer. I will say that I need an office visit. And now I see a list of dates and locations. I need to see her on Thursday. That's my first availability. First thing in the morning, 8:30 is perfect. And now I enter the patient registration portion. I enter my first name and my last name for this, as well as the last 4 digits of my SSN, which I'm just gonna go ahead and say is the time right now, 0740, submit. And we looked in Epic with that information. So that was the last 4 digits of the SSN, the first and last name. We didn't find any matches, so we're letting the user know, you're not in our system, you'll need to register as a new patient. I can click continue. Now I'll need to enter the full SSN since we're actually creating a new patient chart. That is still 0740, continue. We'll say the date of birth.
Were you able to hear that okay? So I think you get the point. So the rest of the demo is just basically entering the demographic information. It confirms that it's accurate. It gives the user an opportunity to correct any mistakes. And then it books the appointment in the electronic health record. It commits it to the record. And we can give options for sending reminders, for providing directions, whatever our customers would like to do in terms of ensuring that there's engagement. So really that's what we're focused on in the hyper, sort of COVID time period, is to help with the offloading of all of these phone calls, helping to shift people from analog to digital, and then really working on that scheduling use case to make that as automated as possible. So I'll stop there.
Thanks so much, Adam. You mentioned kind of this fire hose that your customers are drinking out of in the first few weeks of this pandemic, and how a technology like this is critical. How are you seeing health systems respond? Are they still in a reactive mode where it's like, I've just got to stem the tide, or are you beginning to see some sort of proactive thoughts about technologies like what you're building? Where are you on that spectrum, or where are they, rather, from your observation?
Well, from my experience, I will tell you that most health systems are tech averse, right? So I sat on the health system side for 30 years and listened to hundreds of pitches from vendors that came in with every great gizmo that they could have. And we did not implement very frequently. And then even most recently, a lot of health systems have been scorched by the cost of their enterprise EHRs, and they sort of pulled back again from this whole notion of innovation. But what we've seen as a result of COVID is an acceleration, because for 2 reasons. 1, there's just been this onslaught of care that's necessary. And 2, again, as I mentioned earlier, the fiscal hole that has formed in most health systems' balance sheets have forced them to say, okay, what are the things that we can do that actually lower our cost of care and truly raise top line? So I think that digital health companies in the past that were able to sell themselves on a great vision and a soft ROI are going to have a hard time moving forward. If I were going to talk to a group of young entrepreneurs, I'd say what you really need to focus on is a hard ROI. You've really got to help these systems cut cost. They think that they've cut the fat out of the system, but the fact of the matter is that they haven't. And it's not just about cutting fat, but it's also about making systems and processes work better. And similar to cash, focusing on the patient is really the right place to focus, because they're the ones ultimately that are us, right? We're all going to be patients, and we're all going to want to be able to access care and get information. So I think that there is this sense of, I have a little bit of sense of renewed hope that, appropriate technology will be adopted. It's up to us to make it easy, to make it inexpensive, and to manage a lot of the things that we used to hand off to health system partners and ask them to do as part of a vendor health system relationship.
Adam, I'd love you to embellish just a little bit, and then I want to come back to Cash as well. Embellish a little bit more on that ROI piece, because in a value-based world, prior to the pandemic, it was all about we're moving toward value. We need to have, more appropriate utilization of healthcare services, keep people out of the ER, keep people at home. That was sort of the mantra for forever. And now you have health systems that are feeling financial pain because people aren't coming in for elective procedures. They're simply needing you to do more fee for service. So, and people have been calling this like demand destruction. How do we kind of fill the gap now? So when you're coming in as an entrepreneur with the technology, are you changing how you're speaking about value proposition within, kind of within the context of that dynamic for your customer?
Right. I'm going to leave value alone for right now, because we could have an entire hour discussion on that. What I will say is that outside of California and a couple of other geographic areas, value-based healthcare is a mirage. Health systems are still wed to fee-for-service. Payers are still wed to fee-for-service. And there's not been that global adoption that we hoped would help transform the business model. So the business model is still remarkably fee-for-service in healthcare today, again, outside of a few geographic areas. So taking that into account, we have that really is what informs the business model. So when I came to Syllable, again, to reiterate, I said, we have to be inexpensive. We have to find a way so that we don't have to wait for the next budget cycle. So if it's December and the fiscal year begins in July, we want to be able to come in with a price point that allows somebody to say yes today without having to say, well, budget season's coming in 4 months and, give us a call back in September, and perpetuate that long sales cycle that happens in healthcare. I think the other thing is so that's sort of the CFO argument. You gotta put it in front of the CFO so that he or she can say yes or no without having to say, let's get through the next budget cycle. You have to be relevant, and you have to have enough of an impact that it makes them sit up, and it gets to the level of the C-suite, because we've got to get beyond this pilot and scale concept, because I can't tell you how many pilots I've done and how many haven't scaled. 99% of the pilots never scale, and I think for a healthcare tech company that's not healthy. I think you need to be able to come in and say, we have a mature enough product that we believe from day one that we can become live, and that we don't need to pilot. And if you really want us to pilot, then we're going to pilot for a very short period of time, but then we want agreement, and we'll write it into the SOW that we want to scale beyond that, and we want to scale quickly. Because our business model, we're able to be inexpensive because it's based on scale. So we build the AI once, and then we can deploy it to as many customers as we have. The only thing that needs to get rebuilt is the knowledge base, the knowledge graph. And that's relatively easy for us to do. Our AI does most of that anyway. So we're able to pass that savings and that savings of scale onto our customers to, again, make it easier for them to get to yes quickly. Did that answer your question?
Yeah, no, thank you. That's great and very practical, I would say. So Cash, you launched, last fall before the pandemic. From a business model standpoint, are you selling direct to consumer as well as direct to employer? Is it a hybrid business model? And how are you seeing the dynamics in the marketplace today for a navigation-based AI like yourselves? Because there are many different ways, I think, of quantifying the ROI, based on who your customer is. So I'd love you to speak to that.
Yeah, absolutely. So yes, we have a dual channel approach. We are designing for the individual, and we absolutely work with enterprises to create value. The biggest challenge, even for the most advanced health providers or payers, etc., is no different than what most entrepreneurs face every day, which is how do you create a product that people want and engage with? And if you notice engagement levels across the board, no matter how pretty the app looks and no matter how good it is, it is very challenging to get people to keep referring to you and coming back to you. Nobody wakes up in the morning and opens up their payers app or their employer's healthcare benefits portal and says, oh, I need to seek care, where shall I go? If at all, those tend to be one-off events around checking a benefit or two or signing up for something, and then that's the end of that. So the biggest challenge is, how do you get people to actually want to use you, and how do you be part of a conversation with them, not just dump them into a swimming pool in the deep end and expect them to look around and click on this link and click on that link. So the whole purpose of the Anchor Health consumer and individual focus is to say, if you don't get that right, there's really no point in trying to create yet another solution in the mix that you then try to sell to an employer or work with a partner like a healthcare provider or a payer. And that's that consumer angle, which is really, how do you get that experience right and get it fine-tuned? The willingness to open up the consumer monetization angle is we really have the consumers. Our focus is we've got to have the individuals back, and part of having the individuals back is access. Too many premium resources in healthcare are available only to a select few employers. You know, I've lived that life before. You can see it out there. If your employer happens to have the budget and a forward-thinking benefits department, they will sign up for really amazing digital health tools. If not, sayonara, good luck. So we want there to be an entry point in. For example, health advocacy. If you didn't know about the health advocacy that's available through Anchor Health, you'd be on Twitter trying to find a health advocate, and you'd have no idea how much they charge you, and you had no idea whether they really have the experience or not. It would be a very complex thing to go through. So that's the consumer channel there. We work in partnership with employers, payers, providers to create joint value between them and the individual. So there are plenty of win-wins. For example, if you think about a value creative choice, if you need to get a lab test, where should you go, really? And how do you communicate that information to the individual in their decision journey while they're having that process going through their mind? And that lends itself very much to two aspects. One is a conversation. You know, tell me, what are you trying to get done over here? Oh, do you need a lab test? Okay, you need a test. You need to get this done, or you need an appointment or something like that. And then the second aspect is the where. If you are within one experience, the where naturally defaults to, well, I've got, these doctors to come to me, or I've got, these folks in my network to come to me, kind of thing. But the where could be a much broader thing if we're able to aggregate the supply on the other side of things and allow us to really be able to say, the right place for you for this is X. And in that lies a lot of potential for value creation for both sides. One, help you make sure you get what you need done at a price point you're willing to pay, with the ability to work with you to help you estimate those things where it may not be completely accurate, but it may not be completely transparent from the get-go. Some of it is, some of it isn't, as we all know. But also on the other end to say, well, if there is an individual who is looking to get a very complex cancer treated, touch wood, in this geographical area, it absolutely behooves us as a health system to make sure that that individual is aware of all the latest advances at the nearest academic medical center that is specific to that cancer that is being treated. And that is an absolute choice that can be made there that lends value to the individual in getting them the right care that they need, and also lends value to the supplier of that to make sure that matchmaking happens correctly. One of the biggest challenges that you find when you're a provider, for example, is, are you getting the patients that are right for you? And are you getting the patients where you can actually add value to their care, actually make a meaningful difference in the progression of their disease or the management of their disease? With payers is, how do we actually even get you to know your choices in this area versus just defaulting to, I always go here, I'm just going to go here, right? So how do you interject in that conversation and have the consumer and the individuals back in that process while creating value for the entire supply side of the healthcare system? So that essentially is what we're seeing. Pre-COVID, of course, it existed. Post-COVID, it's become more acute because the ability to deliver services that are not value accretive are severely constrained. The need to do more telehealth out of just sheer necessity has increased tremendously. So even as simple things like digital triage tools or even nurse lines from the insurance company. When's the last time anybody looked at the back of the insurance card and called the nurse line that's available for free to you? most people don't do those sorts of things, but those are absolutely value creative things that are available to individuals that we can surface and make available to you at the time of your decision. Does that help? Yeah.
Yeah. How are both of you being in the AI space and helping with this sort of information at the right time in the right place for the best outcome? We're living in a time right now where the information is changing so quickly. You know, I was just talking to somebody the other day, and it's like the testing for COVID, you know, one day the turnaround time is 7 hours, the next day it's 2 weeks. It depends on where testing is being allocated in the country. Suddenly there may be a huge contract from FEMA and a particular provider of a test cannot respond, Quest cannot respond, LabCorp cannot respond. How are you dealing as an AI company with rapidly changing and incomplete information on testing, vaccines that are coming up, you know, other questions people have? Is this AI's moment to kind of help?
Cash, you want to start on that?
Sure. I think it would be beautiful if it were 100% possible just purely through AI, because it is AI's moment to help, right? I mean, all of these things are optimizations. AI relies on clean data. And the biggest challenge of that problem is that oftentimes the data is stale or the data isn't clean. And so the ability to be able to respond to that is a combination of AI and digital, but frankly, you need a human in the loop to make sense of it at times. And not a human in the loop at every time the individual is interacting. Could be human in the loop at the back end on our side, just to make sure that we are structuring things correctly, that the data is indeed accurate, and we have all sorts of ways of doing that. So that's how we're responding to that. In that we digitize and we use through just pure data optimizations, but then we're also making sure we've got humans that verify certain aspects of it, and then we do our best to keep up to date on both fronts. Adam, anything you'd like to?
Yeah, no, it's a great question, and it sort of takes me back to medical school, and you know they pound it into you in medical school of first do no harm, and that really harkens to the fact that we're learning a lot of techniques, tools, and procedures that can be done to people, but just because they can be done to people doesn't mean that they actually do good for people, and so I think speed sometimes hurts. And I don't want to see speed hurt. So we're not really we are not on the edge of clinical care delivery. We're more on the administrative side of healthcare and trying to speed that part of the journey. We're not yet in the care delivery space. And so, you know, the latest and the greatest is not something we're necessarily going to have our AI out there looking for from a signaling standpoint. We want to make sure that any recommendation that we make is a recommendation that can be supported, because the worst thing I think that we could do is to provide something to somebody that doesn't work, or send them to an IVR that's broken, or send them to a doctor's office where nobody picks up the telephone. That doesn't do anybody any good. So, you know, we're sort of insulated a little bit from that from the medical science standpoint, but yet our bots do give out information. And so, you know, we try to wait for what I would consider to be the thought leaders to make a determination on some of these things, and then we surface that information to our users.
Yeah. If I were to just build on that and saying, you know, for example, in the earliest days, the biggest challenge was, have I even been exposed? You know, what has been my exposure to COVID? That's literally what we were grappling with if you think back to like February. And there were no tools. There were these vague websites that had this complex decision tree, etc. So we rapidly created a digital triage chatbot tool that would be able to just essentially put what the CDC was putting out with their guidelines into an experience that we could deliver. But then to Adam's point about first do no harm, well, then the CDC released their own chatbot. And so then us as a company are going to say, well, we don't actually now need to do this anymore, right? We're just going to actually link to the CDC chatbot because we don't intend to do harm. We're very much focused on helping you connect to the right resource. We only step in and build it where we feel there's a gap in the market. So one of the reasons we created our data set around urgent care and care, for example, is because it's really awful out there. There's a complete gap in the market in terms of being able to reliably get care that is close to you, that is right for you, with all the information that you need to make that decision in one place. It's a combination of multiple tools with this day. So we only step in where that is. If there's a partner that's willing to do that, or if there's a solution that's already doing that, great. We don't necessarily need to do it all ourselves.
That makes a lot of sense. And I think it's just something we're just going to struggle with as a health system in this next year and a half, I think, is just what is good information. And I think, you know, to your point, AI is not going to in and of itself solve that problem. But I think a very essential question for both of your companies, because consumers still want to know and have that confusion. So I want to invite the folks listening to put in some questions for Cash and Adam in the chat, or you can go into that link that Todd put in at the very top. And as those come in, I'll continue to ask questions, but then we'd love to take some from the audience as well. So here's a question for Cash and Adam. So I'm thinking, Adam, you know, the AI is really kind of helping the health system with their multiple front ends, you know, call centers, websites, all the ways they're interfacing with potential customers, patients, consumers, and you know, Cash, a little bit, you're kind of building that advocacy engine for the individual as he or she interacts with a number of different services. Is there going to be a moment where your AI is like meat? You know, like I'm on a health systems website that Cash sent me to, and now, you know, I'm just interested in that, because to this idea of the chatbots of the world, how do they interact with each other at some point?
I mean, I think if you look out far enough, probably there's at some point where everybody's business model around AI and healthcare begins to butt up against each other. And I think that's probably natural evolution. And I hope that people will be smart enough to say, you know, where there's overlap, let's make it easy for information to go back and forth and for knowledge to be transparent. Because in the end, we really all, whether you're B2B or B2C, you want the same thing, which is you want consumers or patients to have the best experience possible. So, you know, I am not the technical person, so, you know, I'm the medical person. So, you know, AI to me is still magic, but I think that in my 14 months, I've learned a little bit on the technical side of it. I think that at least as it stands right now and for the foreseeable future, there's plenty of room to allow the technology to mature and to allow the use cases to mature, so that you know, we really just bring better and better tools to patients so that they can really own their health and get a much better experience than what they've been accustomed to.
Yeah, I mean, I'll just add that you know, what we're seeing is that there is a lot of room to be able to partner in healthcare. It's a necessity, but there's also tremendous willingness. So a lot of what we're delivering comes via partnerships that they've been extremely open from day one. Partners like GoodRx, Headspace, we get content from the NIH. So we're essentially bringing the premium content in a conversational interface that's digestible to an individual on a small phone screen, because nobody thinks about going to the NIH, yet they've got the best information. So we found a tremendous openness to partner. Do the AI backend start partnering with each other in the process? That's a little further down the road, I imagine. But I will say this: if there is an opportunity to do that right and to do that responsibly, I'm just thinking the nightmare scenarios where, you know, we heard about a very large tech company where they devise their own language, if you may, and we don't want to go down that path. So as long as we're able to do that responsibly, as long as we're able to make sure that we are not, because the challenge with anything that you're doing in an automated fashion is you at some point lose control. So there were, you know, oftentimes, I'm sure everybody's experienced this, you're saying something very explicit, but you're getting a strange reaction back, and you're like, I can't be more explicit than what I'm saying. But that's because you've given up some of that deterministic control. It lends itself towards a probabilistic analysis of what are you trying to say, and et cetera, et cetera. So we just have to make sure we're responsible about that. And there's always this tension as we speak right now, where even in the conversation you have with Anchor Health, we have constrained it to a ridiculously small amount of things that you can say and that we'll actually successfully respond to you. Not because we can't do more, but because we can't guarantee that we'll do all of that more in what you would expect and actually guarantee you success. So there are all these ways of creating point and click, constraining the conversation, channeling you to in a conversation that is more structured so we can know what you're trying to get done. that we're using. And because our ultimate goal is not to show you how cool the technology is, our ultimate goal is to help you get things done. And that's literally it. So.
Great. So we have a question from the audience. There's been a lot of talk about medical visits using telehealth. Do you think AI will have a place for pharmacy?
I think that's a great question. You know, I think that I think what we've seen as a result of COVID is now a melding of the technology, the business case, and usability for healthcare. And I will say healthcare writ large. So I do believe that there's an opportunity that it will go beyond just office visits with a doctor or a nurse practitioner or PA. I think that there are other ancillary medical services that can also be delivered in a synchronous or an asynchronous telehealth way. And I love pharmacists. I think pharmacists are the greatest part of the healthcare team, because they not only get the accurate reporting of what medications the patient's really on, because the patient doesn't want to tell the doctor what they're not taking, but they'll tell the pharmacist they're not taking something. But they are also trained in terms of food and nutrition and diet and in those particular interactions with medications. And they have an entire knowledge base that is really very valuable for patients. So yeah, I think there is a future for that.
Yeah, I'll just second that. Absolutely. I think the world of pharmacy, by the way, when you say pharmacy, it is a beast in and of itself, between the PBMs and the retail pharmacies and all the folks involved in that value chain and the manufacturers. And oftentimes even within that ecosystem, incentives are not completely aligned. So it is so when incentives are not aligned, data doesn't flow. When data doesn't flow, there's only so much that digital can do. I mean, that's just the simplicity of why healthcare is such a complicated industry to digitize. Having said that, from the perspective of the individual, we do have a medication module today. It allows you to look up information on a drug. It allows you to look up information on side effects. It could recommend generic medications, and it can help you get discounts. If you can just imagine, you can layer on additional capabilities on top of that would make them more sense for you. So if you were to be working in a pharmacy thing, I would say pick a angle in that what is going to be your focus to come in there. And then from then on, you'll find a narrow beam of light to be able to shine through and actually get done what you need to get done. So.
Great. And feel free to add more questions to the folks listening in the chat or in the link to the platform that Todd shared. So one question I have to ask both of you before you run away is, here's another one from Todd. Do you think the pandemic will have any impact on payer models in the US? Good question.
Well, in a sense, it started to, right? So free COVID testing, well, and it advertised free COVID testing. That's kind of a change, you know. That's not something that that we had really seen government intervention in order to provide that scale of decision-making around the cost of a particular service. So I think that there are signals like that, but I consider myself sort of a cynical realist, and I realize that gravity is hard to escape from, and the fee-for-service model is so entrenched in what we do in healthcare that it's going to take a lot of force in order to move us and to provide some momentum. So I'm hopeful. I'm hopeful that it will. It already has revealed, but I'm hopeful that it will result in really addressing a lot of the disparities in care that COVID-19 has pointed out. I'm hopeful that it will reinvigorate the sense that healthcare, the concept of healthcare as a utility, and healthcare as is not only a right, but a community good, because we as individuals are more productive to a community if we're healthy than if we're sick. But on the flip side, talk about the gravity, many of us who have retirement plans have traditional healthcare organizations in those retirement plans. And so there's always going to be a push and a pull from different sides of the equation to either advocate for or try to obstruct change. So I'll be hopeful in this case and answer your question that yes, I think there will be some lasting positive change in the business model.
Yeah, and just to add on to that, if we leave the whole value thing alone for a second, between fee for service and value, just within even existing constructs, the push towards digital has been significantly accelerated because of COVID. So just to make it very real, even for us, back when I was at Stanford Healthcare back in 2016, we sponsored a bill in the California legislature, if anyone is curious on the policy side, AB 2507. Much of what we were advocating for in terms of accelerating access and reimbursement of digital health capabilities and tools and services are now in law coming from CMS. And as we know how payer models evolve, it's, well, what does CMS do? And then that goes quickly into the commercial payer side of things. So we are seeing a significant acceleration in terms of the regulatory framework for digital health overall. We're also seeing a uptick in consumer expectations and in individual expectations as to what can you expect from a experience in healthcare that is, as other folks have said, that genie's out of the bottle now. It's not going back. So I think those expectations have ramped up. We're also seeing very pragmatic realities on the supply side in terms of what can people actually do in a constrained environment like this, which if it lasted a few weeks, it would be, well, that was an aberration and it's back to business as usual. It's lasted a very long time. So I think even in the delivery of care, we're seeing a massive uptick in how you think about what can be done digitally, what needs to happen in person, how do you structure your organization in order to do that. So I think on all fronts, there is going to be a significant push towards all of that. There's legislation in numerous states around data transparency. That's a constant push. So I think on the regulatory front, definitely the crisis has accelerated a lot of key catalysts and frankly pillars that you would need for the success of digital health companies.
Thanks for those responses. I wanted to also gauge for any entrepreneurs in the audience, what it has been like for both of you in conversations with your investors about how you are thinking of runway and roadmap right now as startups.
Well, I'm kind of a novice, right? So I was in healthcare for 30 years on the East Coast, and I moved here 14 months ago and wasn't quite sure what a VC was. So I've had a rapid fire education to this whole investing engine. And being a novice, I kind of expected what I expected the stock market to do, and it didn't do it. So why is the stock market, at all-time highs when we believe the economy is terrible? I kind of felt that people with money would invest money at times like this. So I've been surprised. The venture capitalists now are looking even harder at areas where they think there will be significant growth and significant chance for success. Because they feel an optimism, or they see something structural in the economy where health tech is kind of insulated from whatever may happen in the rest of healthcare.
And Cash, what has been the sentiment there from Silicon Valley in terms of the pandemic and investing horizons and pivots and balance sheets and all that?
Yeah, I think, it depends on which sector you're in. So generally speaking, it's been brutal for some sectors. And just bringing it home to healthcare, as you've seen over the years, and there's been a trough of disillusionment, and that there's been a lot of potential, there's been a lot of market sizes that are large, but the returns weren't there for the investors yet. And I think what this has shown, the combination of the focus on healthcare, the tailwinds that are on a bunch of different fronts over here, coupled with, we've had some successful companies now that have gone public, that have generated value for their shareholders and for their investors. And as you know, it's a massive industry. It's 3.6 trillion today by CMS projections, if you can imagine it. This is pre-COVID, so I'll be curious to see how it changes if it does by significantly post-COVID. But by CMS projections, we're growing to 5.5 trillion by 2025, not that far off. You're adding 2 trillion more into an economy. That's country-sized GDPs, if you mean, that are coming in. So clearly the markets are there. And the question always was, is it possible for digital companies in a primarily service-oriented industry to be able to generate value in a way that's sustainable and scalable for venture returns. And I think we're starting to see that there's a lot of optimism, and people are now getting back into that and saying, oh, hang on a minute, we may have finally found our crack and be able to, opening is what I meant to say. We may be able to actually go through with it. So.
Great. And then as we kind of wind down here, I'll take questions for about another 4 minutes if folks still have them, and then we'll wind down at about 1:15. But in terms of, if we were to check back in with you in 6 months, what are you most excited about on the product development roadmap for both of your companies? And what sort of next rollout would take the vision further of what you're trying to accomplish with AI?
Cash, you want to start?
Sure. I am just tremendously excited, born out of crisis, but the opportunity has just become so stark in that it is so evident to everybody. You know what you need to get done, and it's still hard to find it. Imagine if you didn't know what you needed to get done. There are very few entities, just putting the Anchor Health hat on, there are very few entities that are focused on saying, we have the individuals back over here. And the opportunity for us to be able to say, how do you today bring the best of digital and augmented humans, and then create synergy between those two so that the humans can inform the digital, and then be able to ultimately know what's right for Indu and recommend to Indu and meet Indu when she's in a way that she's receptive with the messages, is to be able to engage with the healthcare system and extract value from it is tremendous. On the enterprise side, there is a tremendous openness to be able to say, look, we have to embrace this new reality. And that is something that, as Adam was referring to earlier, there are so many priorities that every healthcare enterprise, whether it be a payer or a provider, always has to contend with, that while everybody knows this is important, it was not more important than creating a new, OR, if you may, or something, if you were a provider, or if you were a payer actually taking on a new market, even if it meant going on with traditional ways and getting that network design right, if you may. But now now putting the individual at the center has become so paramount, and servicing their needs in the best way has become so paramount. And the opportunity for AI with the data flowing is just so tremendous that this is an extremely exciting time. From a roadmap perspective, we're only going to be expanding our use cases to be able to integrate more solutions. We're just constrained by our ability to say we have no dearth of people wanting to partner and saying, hey, listen, could we access people? Folks that have raised 300 million in capital and have been out there for 10 years to companies that have started a year ago. So the ability to actually go and execute on all of this and create a cogent experience around it and bring that in an umbrella platform for an individual is just tremendously exciting for us. So.
Fantastic. Can you say how many partners you work with now, or is that secret?
Oh, no, it's not secret. I would say, it's just too many to actually list. I've never actually counted exactly how many, but what I can say is we've got multiple categories of partners, and this just gives you a sense of how it grows. We have content partners that provide us with the best content that we might want to give an individual. We have digital health startup partners that essentially needs to grow and scale their own business. And with us, they find the synergy in order to be able to do that. Often those are point solutions. That could be a drug discount, for example, or that could be, other areas of digital. There are your employers who essentially say, listen, I've got a global workforce. So one of the other things we did during COVID was we went live on Messenger, as I mentioned, but through that, we reached 72 countries, individuals in 72 countries in 30 days. And clearly it surprised me. I thought we'd go beyond, we'd go with the usual suspects, if you may, of the large health economies. But what that just showed me is that there is global demand for this. And the US system is probably the most complicated in the world, but there's always a need of an individual to take care of themselves. And there is no system out there that is hitting it completely on all fronts, if you may. So the need may change. It may not be as much of a payer mix or a private insurance complication that someone's dealing with. But so there's global demand. So we have essentially partners that help us scale globally. There are provider partners, payer partners, employers. With the employers, global became one of the biggest things in terms of what they wanted to know from us. That was just heartening to me, because in my prior life before Stanford Healthcare, I used to be at McKinsey and HP, always been in global focused roles and organizations, if you may. So the ability to say, hang on a minute, we can actually take this to be much bigger than what it is even today. Obviously, we're starting in the US, was tremendous. So there are partners in each of these areas. We're also very heartened, and I'll end with that, with the technology platform partners that we have. So the ability to do today what we are able to, which is aggregate records across 10,000 facilities, put that in the cloud, feed that to the most modern CRM experiences, have that then loop back into the digital platform, and have that also be presented to the humans that are advocating, if somebody happens to call our advocates, in one seamless motion that feeds everything, was just this pipe dream a few years ago. No one thought that, like, wait, you can actually do that. But we have, and these are partners like Salesforce and AWS and OneUp Health, and so it's just it's just been a very heartening to see what the capabilities of the platform are. And then last, on the platform side, the conversational AI is just growing leaps and bounds. I mean, there's the OpenAI project doing amazing work. There's RASA that's doing great stuff. So we have a lot of stuff ahead of us that's going to be very exciting.
So sort of an infinite product roadmap, and the only constraint is how quickly you can get to integrating these wonderful partners and creating that cogent experience. Is fantastic. Adam, what are you most excited about on your product roadmap? What can we look out for, and what are you constrained by?
So I'll take the inverse of that and sort of give you the vision. So the vision that both our CEO, Cobus Houston, and I have, and we talk about this frequently, is that we'd like to get to the state where our mothers no longer have to call their sons for help navigating a healthcare system. So our goal is to create the experience for them so that it becomes easy and seamless to get care when they want to get care, and they don't require having somebody else who's a little bit more tech savvy or a little bit more clinically savvy in order to help them to do that. In order to do that, what I'm most excited about is the whole concept of the analog to digital transformation. So it's identifying the top use cases, the short part of the long tail that's going to drive, really the movement of people off the phone onto the web, because that'll be good for both the health systems in terms of helping them to reduce cost, and it'll be better for the patients because they'll be able to get better service. They'll be able to get some self-service. They'll be able to complete some transactions online. And I think that will speed people getting care, as opposed to people hanging up and not getting care because they're not treated the way that they want to be treated. So it's the call centers is incredibly big for us right now. Doing self-service scheduling is very important. Rethinking the whole digital footprint for a hospital and helping hospitals rethink their whole digital marketing strategy, I think is very exciting for us. And thinking about some new tools that can be deployed easily on websites just to reduce the opacity that exists and helps people get to the endpoints that they want to get to.
That's a great answer. But thank you both. So we have one last question here. What role do you think universal electronic health records will play in the development of digital health? Are we going to get to universal EHRs? And if so, what role might that play?
Yeah, great question. I mean, there is that EHR that will remain nameless, to paraphrase Harry Potter. Yes, I think eventually consumers will own their own data, and there will be a methodology to have some sort of universal EHR or universal access to one's own personal information, assuming that individual gives permission for another individual to view it. It just has to happen. I mean, and I think we're seeing both the regulatory push in that direction, and we're seeing the consumer request for it. I know as a provider, and I know my colleagues as a provider, it's just a mess. It's complicated. It was never, the current EHR iterations were never really meant to be useful tools for clinicians and patients. They were really glorified cash registers, and they were funded by the federal government through meaningful use. So I think the incentives for their development were wrong. I think the targets for their development were not consumer or practitioner focused. So there will be another iteration, whether it's truly universal, whether there'll be one system, or whether it will be interoperability that will enable multiple providers of EHRs to remain in business. I think, you know, that's the question that will come down the line. But yeah, I think we'll move more towards that rather than proprietary systems where data is locked up.
Yeah, and I think, I mean, just building on that, ultimately, I think the use case and the most powerful thing is a health record, using the English terminology, not necessarily the industry system thing of EHRs, is having a health record that covers the entirety of your universe. So when you think of a universal health record, as long as you are able to gather, harness, refer to, and share what information pertains to your universe in terms of how you seek care, in the different ways you may seek care, and be able to use that to the benefit of your healthcare when you seek a provider or for your own reference as you make decisions. I think that's a dream that we can all aspire to. And that is something that we actually see a lot of technologies enabling a lot more. And that does not require a rip and replace of massive systems that have already been deployed, which is completely unrealistic. People have spent billions of dollars on specific EHR implementations to somehow think that there is now a version 5.0 that's going to come out and going to now all of a sudden everyone's going to be like, you know, I just advocated for this massive system. And now I think it's not that great. It wasn't that long ago, but it's not that great. I'd like to replace it with this new shiny one. Good luck getting that past the board, right? So I just don't see that as being a very pragmatic or even the right thing. It'll just add a lot of cost. I think you're much better off saying, how do we make sure individuals are able to get access to what they need and be able to use that to their benefit whenever they need to, with whoever they need to.
Welcome to Joe Bhakdi. I am delighted to be in conversation with him. He is the founder and CEO of Quantgene, which is a real-time medical intelligence company based in Los Angeles. And they've created a genomics platform to allow for the early detection of diseases. And Joe is going to be telling us a little bit today about their work on machine learning, sequencing technology, and DNA extraction. However, Quantgene has also made a really fascinating pivot during this pandemic into the world of testing for COVID. And I would love to introduce Joe to have this conversation with us. Welcome, Joe.
Hi, Indu. Great to be here. Hi, Todd. Yeah, it's a pleasure to be here.
Fantastic. So let's take a step back before we get into what Quantgene is doing right now to respond to COVID. Rewind the clock a little bit for us before, if you will, the pandemic, and kind of fill us in on the problem that Quantgene was trying to solve and the observations that led to the company being started. Absolutely.
So we started in 2015 at UC Berkeley, and what we saw back then, you know, we were a team with different backgrounds. I'm an economist, quantitative math, like a lot of like quantitative modeling across different industries. I have a lot of friends in biotech and in medicine. I also come from a very medical family, so all my relatives and parents are bioscientists, and my dad is a professor for microbiology. Very outspoken on COVID, by the way, in Germany. That's a different story. And yeah, back then I was getting very involved in genomics and also with cancer. We have cancer in the family. I'm very personally exposed to it. I think a lot of people are. And you know, what struck me back then is, you know, this bigger picture, what's happening in medicine, that medicine and deep biotechnology are turning from that very slow moving, very wet laboratory driven field or subject into something that is much more data driven, and that turns all of biology and most of medicine into a data science business. And that means literally the way we protect and extend human lives will become more and more something where it's about testing, diagnostics, and complex, you know, statistical frameworks that tell you, Indu, based on your genetics and the current testing results, there's nothing wrong with you right now, but if you don't do certain things, you are running at risk in developing something in 5 years. That sounds like science fiction, but actually it's what Quantgene already does today. And it's extremely exciting for us to have some of the best machine learning, data scientists, and software engineers working together with very forward-thinking physicians and biotech people. So what we saw back then is there's an opportunity in detecting cancer at early stages in the blood through deep genomics. So that means a new form of sequencing that we developed that uses conventional cutting-edge platforms like Illumina NovaSeq, or before that NextSeq in 2015, there was no NovaSeq, and adds software layers, statistical machine learning layers, to do a large range of things. So it develops, it's a bioinformatics pipeline that allows you to read out of billions of reads, billions of nucleotides reads you get out of each sample to determine what is a mutation, what is not a mutation on all the cell-free DNA fragments, to determine what's an error, what looks like a mutation but was a machine error, and so on, and then take these very complicated mutational patterns in the blood and detect cancer in them, detect cell-free DNA fragments that stem from tumor cells. That is all things where you need a completely new type of company and a totally new type of technology, because you have to ramp up the way and scale we normally look at data in medicine, not by a factor of 1 or 2, but by a factor of 5, 10, 20 million. And it's literally when a doctor sees that, they don't understand what we are doing. So normally you have a PSA test or cholesterol, you have a single data point and it says, well, you have 160 cholesterol or something. In our case, you get literally 6 billion of these data points per patient. So if you it's like giving a doctor 6 billion cholesterol sheets to read through and decide what's going on. That's going to take a long time. So you need to completely rethink how you do medicine. You have to turn it into a very large scale data operation, including complex cloud systems that we have now. And then you have to develop systems that integrate all this data and the different layers of statistics, with analytics, but also with clinical algorithms and also with laboratory workflows. And that's exactly where we had a leg up with COVID when it happened. So it's really a totally new form of company we are building that is extremely software and data driven, but doesn't shy away from going very deep into laboratory details.
I want to come back to the laboratory piece, of course, in a minute, but I want to stay on the blood for a second. I was really fascinated to learn, just listening to you, that when I think of genomics, you're right, we would think, well, just go into the cell and go into the DNA and then do the fancy stuff you guys do. But you're saying that when you're dealing with a blood sample, you have these other fragments that normally you wouldn't have to, it's almost like I'm hearing you say you wouldn't have to weed that out in a sort of traditional genomically gathered sample, and that the blood introduces a lot more noise. And I find that fascinating. So I'd love you to just say a little bit more about the state of the art in detecting cancer in the blood, and what you guys are in that state of the art. What is that piece that you've refined?
Absolutely. So my thesis from the beginning on was that in order to detect cancer or any dangerous disease at early stage in the blood, the only biomarker that works for extreme precision detection is DNA. And that is because DNA is digital. So if you have a mutation on the DNA, you have the mutation. You don't have 50% of the mutation or like 0.5%, you have the mutation on that specific fragment. As opposed to proteins like PSA or even cholesterol like lipids, where you have never one molecule, right? You have you have 10 million, but you should only have 7 million. And no one can even count them. So you weigh them, which is ridiculous for precision reasons. So DNA is very good for high resolution. Now the problem is a big source of confusion with that technology, with bringing that big vision of early cancer detection in the blood to everyone, is that it's hard for the layman to understand the difference between hereditary testing and somatic detection. So hereditary testing is 23andMe or Ancestry. And so how this works is, you said you go into the cell and you look at the DNA. That's roughly what it is, but technically speaking, what it does, it randomly picks a bunch of DNAs from you, from your healthy cells. It picks 30, sometimes 100, sometimes 10, depending how much money you spend, and looks at the DNA of 100 randomly selected cells, and then builds the average at each location. So if it's a T at location, 2 billion, 300 million something, and then you see 90 times a T and 10 times a G, then it basically tells you, Indu, you have a G. That's it. They don't even tell you about the T, because it's just, they don't know what that is, and that's probably an error.
That's not a mutation. That's an error.
Well, it might be a mutation, much more likely it's an error. So that's why they look 100 times to create the average, to say, well, there are all these technical errors in sequencing. And the way you mitigate them is you take this cell again and again and look 100 times and create the average, and no one cares how many other things are in there. That makes sense for hereditary testing because all your cells have the same DNA. So who cares if a bunch of them don't have it? I just want to tell you what your genes are. In our case, we have a totally different objective that is, thousands of times harder. And that is to take not randomly 100 cells from your blood, but every single fragment of DNA that is in a blood sample. And ideally don't lose a single molecule, which of course no one can get there, but we are pushing the technology as far as we can to that. Capture all of them and then sequence all of them at specific locations that we know are associated with cancer, which is tens of thousands of locations. And then, now comes the hardest part, we have to make sure that if there's a single fragment in there, a single molecule of DNA that carries a single mutant, that we see that. So we don't average it out, we do the exact opposite. We try to drill down into every single molecule of DNA and make sure we capture that. And after we capture it, make sure it's not mutated. If it's mutated, then comes the really hardest part. Then we have to figure out, is that mutation real or is it a technical error? And that, I can tell you, is a little complicated.
Incredible.
So you need you need a tremendously complex mathematic framework for that. To basically, it's not even machine learning. This is something else. It's signal processing, where you basically have to determine if you have a signal. It's basically having a camera with like 10 billion dots in the camera, and you take a photo and you look at every single pixel. And you have to tell me if the color you see on this pixel is true or if there's an error in there. And that's not easy.
Like you have to have extreme resolution, but once you have that extreme resolution, you have to distinguish in everything that you're seeing what is actually signal.
Exactly, and you have to do this through multiple tricks that are complex tricks. And one of the tricks is you have to take multiple photos of the exact same thing. So if you had a satellite, looks down with 10 billion pixel resolution, just take the exact same picture 5 times or 10 times, then overlay them and say, well, I hope nothing moved while I took the pictures. And now I can compare that pixel. Is it really the same pixel at the same time? But it's exponentially harder than what we discussed before. Because before you just have randomly 100 cells, you know the location, you just look at the 100 cells. Here we have something incredibly complex, because how do you even do that with molecular fragments? How do you look multiple times at the same fragment? And there are trillions of fragments in that sample. And you have to make sure, well, how do I know it was the same fragment that I looked multiple times at? So it's a little complex that involves chemistry. You have to actually literally put molecular markers on every single of these trillions of fragments, and then recognize that marker, and then sequence it multiple times, and then match everything. And you have to build cloud systems that can digest, file sizes of 200, 300, 400 gigabytes per patient.
And that's one diagnostic sample, right?
Exactly.
For one patient, right? That's incredible. So that tells us a little bit about the scale of testing in the blood for cancer. So here you are doing this extremely sort of, quantum level analysis just on this first sort of goal of the company. And then February happens, right?
Exactly. So we were in the middle.
What went down?
It's super interesting. We were in the middle of actually getting to the end of the funding cycle. So we were looking to the next raise, and then COVID hit and everything got thrown off. Like all the VCs, everyone stopped doing anything, because no one knew if the world is going to end. Now we know financial guys are all fine. But what happened in the meantime, we prepared for, okay, this could be really bad for the company. And we were then looking at COVID and, try to figure out what the problem is. Like, why don't we have all tests every day? Why can't we just test everyone? And the biggest problem is this combination of high precision molecular diagnostics, so high quality PCR tests that test with 99.99% accuracy, and fast turnaround times. Because if you have COVID and you get tested and I tell you in 3 weeks, congratulations, you had COVID or not COVID, like you were either dead or infected a bunch of people, or if you didn't have it, you were like scared for 3 weeks and you couldn't do anything. So it defies the purpose of a test to not give people the results fast. And now what happened is in the lab, when we analyzed that labs are just fundamentally not prepared for emergencies at scale testing with fast turnarounds. And what we saw is there are a bunch of smart software people who tried to solve the problem, but they had no clue about labs. So they went in, first of all, they're still not at scale, but they went in and tried to do some workflow software and say like, well, once you're done with testing, type it in here and we report it to people. First of all, the labs didn't know what that software. It's all little startups. All the big labs don't have it. Second, it's not about just a cloud solution to report the results, so you get it. You need to streamline the entire laboratory process. And that means you need to streamline the collection process. So you need a software that is horizontally and vertically integrated. So horizontally across the process, when you sign up with Quantgene, you are in the system. Then you pay with your credit card or your employer pays, you get registered, you're in the system. The nurse collects your sample, she does one click and it's in the system and she ships it. The lab immediately, the same second, sees your sample with the ID and everything. They batch you automatically into these PCR plate batches. I'm giving away all the secrets here. But the lab also is like dramatically accelerated because we basically turned the entire workflow into software, which cuts out at least 4 hours for the process without the administration, just the laboratory workflow. And so then the lab has it fully integrated and then you click another button and you get the results. That's why we can do 7-hour turnarounds right now in LA for movie sets. And yeah, that was a huge Herculean-like thing to develop such a complex cloud system so fast. Fortunately, we had some of these systems in place for our existing labs, but we had to do a lot of adjustments. COVID is, of course, infinitely simpler than what we do otherwise, but the workflow, there are a lot of similarities. We had to add a lot of nurse coordination and concierge coordination and employer interfaces and all these things. But that's why we're a startup. We had to do it fast. And yeah, now it's a very exciting thing now. It becomes a very important vertical for us. Movie industry and government is the most important 2 segments right now, LA County and lots of Hollywood productions. And yeah, just today and on Wednesday, we had like a large movie production. They need turnarounds. They give us this, they do 1 test per minute collection with our nurse infrastructure. And they bring it in by 11, or we bring it to our lab by 12, and they have the results by 6. That's definitely the fastest turnaround in the nation. And there's no doubt about that. And now we are basically offering this more and more to financial institutions in New York, for example, to more movies in Atlanta and Hollywood. We just have to get the word out because it's all chaos. And be smart how we scale it. We want to guarantee that quality and that reliable turnaround. And it's very easy to overscale quickly because there's an enormous demand, but it's also very easy to fail, right? You need fully integrated labs. If you go to other sites, you need new labs. They need to be super trained. We have a lot of oversight quality control in there. So every lab team gets basically an operator in the headquarters to overlook them and calls them every 2 hours, which is key, and make sure they press all the right buttons to keep the process moving. So it's a huge logistical operation, but it's also very rewarding because we see suddenly people can, get back to movie productions. The LA County can do stuff that I can't disclose, but they can do important things. And yeah, and I think there are more industries to come. We have some hardware manufacturers who are also now getting back to work because of this. So for us, it's kind of I mean, as a startup, it was a big transition from doing something so futuristic and long-term, because it's deep research and, you know, this is very complex and you have to convince physicians and everyone what this even is and explain it, to the exact opposite, right? To something where everyone's like, you don't have to explain what COVID is. Everyone is like going crazy for the right reasons, and they need a solution and no one can give the solution. So now we are in full operation mode. But it's very good because we basically we can skip our, you know, VC funding round. We're still open to a nice VC who's like strategically sound, but it's not required anymore. And I think it's healthy for the company to be a little exposed to like a extremely like pressing real world problem.
I just want to just reflect back to you that's right. You kind of went from kind of a demand side problem to like a supply side, you know,
yes,
issue. And I find that fascinating. I also find it fascinating that, however, that scale that you were taking on in sort of the blood-based oncology testing, in a way you're applying to administrative processes now, you know, because I think the solution, as you said, the rate limiting step to you offering this testing isn't necessarily the science. It's these sort of workflow and human processes, but that is the problem to solve. You know, it's not like that's easy to do either. So
exactly. Yeah.
If I were to ask you a question, is looking ahead as this space evolves, how would you rate the challenge of the logistics and the workflow piece of testing versus the science of it? Is it both that are still the challenges?
I would say the science is 0% literally, because it's completely solved, right? So you have basically 100% accuracy tests. We just don't say 100% because no one likes 100% in diagnostics, but it is 100%. So like just statistically, it's 100%. If you test these tests, they never miss a single sample. You're just cautious and say 99.99. There is no problem. You have the primers, you have everything you need. It's an RNA test, absolute precision. So everything boiled down exactly as you said, to a logistics problem. A real, and that's exactly the positioning of Quantgene. We deliver real-time medical intelligence. We are the leader in real-time medical intelligence that applies to cancer and deep genomics, where we basically had the real-time part more as after we do this with you, we can continuously monitor you and also give you insight into any news on Earth that ever comes out on any of your variants. Same with our hereditary product. We have real-time medical intelligence because we can look at your hereditary genome and tell you at every point in time if anything somewhere on Earth comes up that tells you anything about your genes in real time. And now we just apply that real-time expertise into a workflow logistics problem and say, well, we need real-time testing for COVID. Of course, it's delayed 6 hours, but that's better than 6 days. And it all boils down to efficiency. And you're absolutely right, pointing out this is a systems problem. It's a problem where you have to not think like a classical logistics driver or someone. You have to map it all out as a complex logistics system. How many samples come in from where, who drives it where, how is this recognized in the system, and what parts of the system can you cut out? How can you make that leaner? What do you actually need and what do you not need in order to have that final result out? You want to know at some point as fast as possible, not detected, or invalid. And that's the only thing that we need to achieve. How can we get to Indu in the shortest period of time from drawing or collecting the swab, this result back to her? Nothing else counts. And that's a totally new perspective for most laboratory people. And that can be solved through, you know, smart software and workflow systems.
How optimistic are you that this increase in efficiency and more intelligent systems, how optimistic are you that this stays around post-crisis and that actually begins to change the healthcare system?
I have no doubts that this is gonna stay. It's like this disrupt, because we work with many labs now. They can't even believe what's happening, right? Because you have to look at it from a lab perspective. First, they're all skeptical. It's like, ooh, fancy new software. We are very skeptical. There's a very simple thing that happens once you go in, where you don't have to pitch them along why this is amazing. They just look at their worksheets and their people. You know, we come in and suddenly, you know, they can cut out 40% of all hours. It's just gone. They don't need the people anymore. I mean, that might be bad for jobs, but it's for the lab director. It's like, wait, what? I can just, these 6 or 8 people who sit there and just type in samples that are coming and then call people and report it back. You don't need them anymore. You need one lab technician that clicks a single button and you're done. And you literally save, if you have a workflow of like 300 samples a day, you save 6 full-time workers. And you get rid of a ton of, you know, errors. That's the next thing. Lab technicians, same thing. We cut down lab technician time, you know, by 50%. You need 50% less lab technician time. You can double your workload with the same amount of people. So they are pretty easily sold once they see that, and they're definitely not going back, because it would be crazy.
That's optimistic. Yeah, and I think same thing with any aspect of healthcare delivery. You're speaking about laboratory workflow, but I would say that applies to just workflow in the provision of healthcare, period, you know, in clinical environments. I know as we wind down, there's so much more to talk about here, but I am curious that when COVID as a disease, you know, we're learning more about it, and the fact that it's been called, you know, an issue of blood oxygenation. This is not a respiratory illness. This is a blood illness. That you and Quantgene being in the space of studying the blood, are there any interesting ways in which we're going to be able to connect the dots in terms of your prior business in, you know, detecting oncology in the blood and this new sort of pandemic?
So what my perspective on that, and that's also the core positioning of Quantgene, is that when we say real-time medical intelligence to protect and extend your life, that's what Quantgene does. We view you basically as like, I mean that in the best possible way, as a pie, right? As a pie, a statistical pie. And that pie tells you what's your biggest risk of death, of premature death. We want to shrink that pie, ideally to 0, and then you don't die anymore. It might be difficult, but we want to shrink it down. And we want to understand in the pie, what of all things in your life is the most likely to be a big problem for you. And then we want to hit that thing and make it smaller. If it's cancer, then it's cancer. Let's focus on cancer. Early detection and screening, looking at your diet and everything else. If it's cardiovascular, it's that. If it's diabetes, it's that. If it's neurodegenerative or inflammatory, it's that. If it's infectious diseases, because you're very old and susceptible, it's that. So, you know, that means that I think medicine in the past was conducted in these silos. We thought COVID-19, oh my God, let's just figure everything out about COVID-19. And then you die of cancer, right? So it's like, great, it didn't help you. So, or you're afraid of cancer and you die of COVID-19, and that didn't help you. So we want to really take a step back and say, what, on a higher level, what is your statistical risk for what? And so that's how we look at COVID. We look at COVID, not so much the disease mechanics, that's always good to know, but that's not going to move the medical needle too much. What we are looking at is the statistical layers, like who's actually susceptible to COVID and who's the most hit by COVID. So therefore, who should focus on COVID the most, and what is the environment around that person that should watch out? And that's the grandkids and grandparent example. Children are less likely to die of COVID than of the flu. So for them, it's like an incredibly not dangerous disease. It's very different for elderly people or for anyone who's exposed. It's far more dangerous than the flu. So we have to understand that. It's, you know, you can't just say COVID is more dangerous or less dangerous. It depends who you're talking to. And the vision of the future of medicine that we have is to take that step back and look at everything from a really like AI and data-driven perspective and say, no one cares if you gave them all the cancer protection in the world when they died prematurely of a heart attack. And no one cares if you had all the COVID testing in the world, you know, if they died of cancer. and no one cared. You made totally sure they're not getting diabetes despite being exposed to it genetically, and then they die of COVID. So, in the end, it's not disease-centric how we approach this, it's patient-centric and making sure how can we keep you safe. That is a totally new thinking in medicine because it's purely preventative, fully preventative, very statistics-driven, which makes it so beautiful for AI. And it's very new. So most doctors have a hard time wrapping their head around. Some are very forward-thinking and understand preventative care. But COVID is a great example. Like, that's how I look at COVID. We want to be on top of it and say who's actually at risk here the most. Not just one person, but also their network. And I think that's the future, right? This is the future of COVID and dangerous pandemics, to have much more sophisticated systems in place that go away from a siloed disease mechanic and go into population level, networks. I think of it much more like Palantir, right? When you think of Palantir, this global safety, like intelligence network for terrorism and stuff, they are little terrorists. They're like virus terrorists. They're viruses that kill us. And we need to contain and control them in the same way. We have to understand where are our at-risk populations, how are they getting exposed, and how do we deploy testing in a structurally sound way. One piece is to have rapid testing like we offer now, but it needs to be embedded in much more complex systems. The hard part for us is we can't do these systems if we don't get the data and the government involved more, or like large systems, but I think we are getting there at some point.
That's an incredible vision. So we will have to solve population health in our next conversation. We'll have to solve job loss from AI in our next conversation. But it's fantastic. And we're really proud that you guys are in Santa Monica and one of Los Angeles's own. This is AI LA after all. So thank you so much, Joe, for chatting with us today.
I really appreciate it. It was a pleasure, Indu. Thank you. And
that brings us to the end of this panel. Thank you also for giving us, I think, a sense of optimism of where this pandemic is leading us, both in terms of innovation, the mother of all necessity, as they say, invention is. And so I think we are just really grateful for your time today, and thank everyone else for making it out to this session via Zoom. I'm going to hand over to Todd, who's going to tell us a little bit about how we can gain access to this content and other great things AI LA will bring to us. Thank you, Todd, for having us.
Thank you, Indu, and thank you, Cash and Adam, for an amazing conversation. It was great to learn more about what your companies are up to and just how you really are taking, doing your best in these hard times. And so, yeah, again, we host an event every Thursday here on Zoom. You can join us on joinai.la. We also have a book club on Monday if you want to join us there. But yeah, I just love to close out saying thank you all for joining us today, and please stay safe and please be, if you guys like to, we upload everything onto YouTube, so we'll be sending an email after this. So if you did miss anything, you would be able to rewatch this and send it out to your friends. And then also, if Cash and Adam would like to share any of their final screens they had, I think that would be great. But yeah, again, thank you all for joining us today. Please stay safe and healthy, and we hope to see you next time. So thank you.
All right. Thanks so much, Todd. Thank you, Indu.
Okay.
Great to see you all. Thank you all for joining.
Thanks, everybody. Appreciate it.
Thank you.